Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, here with my illustrious and excellent colleague, Dr. Millicent Ravello.
Good evening.
Are you feeling illustrious and excellent?
You know, when you say that I am, I definitely feel like I am.
Well, you are. And that is why we're here to talk about capsular contracture.
That is a big, hefty concept, capsular contracture. What does that mean?
Well, we're talking about breast implants. And who doesn't like breast implants?
Nobody that I know.
Everybody likes breast implants. There are some people who don't like them. There are some people who don't like them. They've had them taken out.
Most people like breasts.
Yeah, they do. Yeah, that's true. All right. But capsular contracture makes breast implants not so fun.
Not so fun. So capsular contracture is something that happens in patients that have breast implants. And it could be breast implants that were put in for reconstruction, that were put in for cosmetic purposes. Regardless of the reason why they have implants, they have implants in place and they've developed a complication of the breast implants, and that's referred to as capsular contracture. And capsular contracture, what happens if you put a foreign body into the body, whether it's an ortho piece of hardware or whether it's breast implants, the body's natural response is to form, or put a cell phone, put anything. You can literally put anything in the body, and the body's response to it is going to be to form a capsule. And it's just the body's way of walling off that foreign body from the rest of the actual body. It's sort of a protective mechanism. And usually in the breast, around a breast implant, it's a very filmy, soft, flimsy layer. And that's normal. Capsular contracture is when that layer of capsule becomes very thick and becomes a problem.
And it does contract. It literally squeezes because of the whatever's going on in the implant, in that filmy layer. It's deforming the implant.
It's deforming it. So if you think of contraction is exactly what it's doing. That capsule around the implant is squeezing and getting hard and deforming the breast and the implant. And so there are various, we call them grades of capsular contracture, which go from very mild to very severe. So you may have a very mild form of capsular contracture where maybe you're the only one, you and your doctor, that can tell you have it. If you are manipulating the implant or feeling it or touching it, it just feels a little bit firmer than it should. And that most people can live with. Now, when it starts to actually look bad, where it's squeezing around the implant and forming it to this kind of hard ball stuck on the chest look, that's getting a little bit worse, and most patients don't like that. And then the most severe form is going to be when it actually hurts. It's actually causing pain.
And those are what you just described as the Baker scale.
Yes.
There's Baker 1, Baker 2, Baker 3, and Baker 4. And those terms are key because a Baker 1 is normal, Baker 2 being, as you described, it's a little bit firmer. You can tell there's something there, but it doesn't look bad and you can live with it.
Yeah.
Baker 3 being that, it looks bad.
It looks bad.
And Baker 4 is it looks bad and it hurts.
Right. And so 3 and 4, those grades of 3 or 4, is when you're talking about having some kind of revision or procedure done to fix it. But I think before we go on to how we fix it, let's talk a little bit about why it forms, which is sort of a black box in some ways. Everyone always, well, what can I do? How can I prevent it? How does it form? And the big picture answer is we don't necessarily know who is going to form capsular contracture or why it happens. We have a lot of theories as to why it happens, and I think a lot of surgeons have modified their technique over the decades. We do know that there is some form of bacteria or a biofilm that forms and leads to it. And so with the advent of more antibacterial irrigations and different ways of putting in implants, I think we've decreased the amount of capsular contracture we're seeing. But the big picture answer is we don't really have a solid answer as to why some patients form it and some don't. We just don't know.
I'm a biofilm believer. I am a low-grade bacterial contamination guy. I think those things are real. I do think that the number one reason why capsular contracture forms is because of bleeding into the pocket.
Okay. I will agree with you. I don't know if that's the number one reason, but I agree that it's a reason.
Yeah. I think I think if you do not stop the bleeding in the pocket, before you put those implants in, you don't have a dry operative field and you get blood in there, that blood is very irritating.
And it's a medium for bacteria. So you may not necessarily have a florid infection in your breast. You might never be a patient that has a breast implant infection. But if there's any kind of low grade or mild, tiny amount of bacteria around that implant, you may end up having capsular contracture in the future. And I think there is a caveat to that. Just because you get capsular contracture doesn't mean that there was a problem with the way your implant was put in. It doesn't mean that your doctor didn't do everything right. Sometimes these little bacteria just get in there, or sometimes you just get capsular contracture, but it doesn't necessarily mean that the initial surgery was done wrong.
No, the capsular contracture is a potential complication of breast augmentation. It is not, and even in the setting of completely excellent surgery done excellently by,
it can still happen.
You still can get it, and the way that you know that, when the patients are signing their consent forms and it says capsular contracture is a risk of breast implant surgery, well, you can't consent to malpractice. So it's not malpractice. It happens.
It's just something that happens.
Yeah, it's not great. It's whatever, but that is a risk of surgery, and it is not, it happens, without negligence. It happens in the setting of amazing surgery. You still can get a capsular contracture. Yeah. And it sucks.
But it definitely happens. And I think that there are some time courses to capsular contracture. You certainly can see it early. I mean, I've seen it as early as 3-4 months, and that's not uncommon if you're going to get it. But sometimes you see it at 1 year, 2 years. Once I think you've hit the 2-3 year mark, you're probably okay. But then I think you're at another risk once you start getting the 10-15 year mark.
Correct.
Then it goes up again. So it sort of, goes in these waves of occurrences.
What would you say the percentage of breast implants that wind up with a capsular contracture? What's the kind of like, it's going to be 10%, 7%, 12%?
I think that's a tricky number because
it is. That's why I asked.
Because I do think that our numbers are decreasing, because I do think we're getting better. So if you're taking breast implants as a whole, the number of implants that have been put in since 1960 or whatever, that number is going to be high. And the order of, up to, I don't know, 7, 8, 9, 10% if you're looking at patients who've had implants in since the 60s. But I think if you're looking at the cohort of patients that have had breast implants put in by board-certified plastic surgeons over the past 5 years, that number's going to be a lot smaller. I think you're going to look something in the order of 3% maybe.
I agree with you. I tell patients that, depending on the study, depending on the implant, depending on how you want to look at it, the range of capsular contracture is anywhere between 7 and 15%. I mean, but
because I think long term, if you leave implants in for 20, 30 years, you're going to have capsular contracture.
Yeah. So it's hard to tell.
Yeah.
If it happens to you, you think it's 100%.
Of course.
So, capsular contracture it's a setback because, you have to deal with it. There are medications we can give, Accolade or Singular, which are asthma medications that just serendipitously were discovered to soften capsular contracture in asthmatics who had breast implants. And then I think there's actually an FDA indication to use them now for capsular contracture, but they don't work in all patients.
And by work, I would say it would be patients that you discover it very early. They're that grade 2. And maybe they never would have gone on to be grade 3 or 4 anyways, but you give them 6 months of it, they do fine, they never have any problems again.
Yeah, and so those are the other option is, surgery.
Surgery.
Yeah, and do you switch the implant whenever you do a capsular contracture?
So the treatment for capsular contracture, assuming you want treatment, you're at that grade 3, 4 level, at that point, medicine's not going to work. The only thing you can do is surgery. And my treatment is to go in, take out the entire capsule, take out the implant. I will consider putting it in a different pocket. So if it's over the muscle, maybe putting it under the muscle.
Really?
Yeah.
With the capsular contracture?
Mm-hmm. Yeah. I get a little aggressive with capsular contractures. If I have the chance to do everything possible, I will. Now, some patients, I can't switch the pocket for whatever reason. They have really thin skin. I just can't. But if it's a feasible thing, I have a lot of patients who have implants that were put in many, many years ago in a subglandular position above the muscle. Yeesh. Those patients, it's easy for me to just switch it out, put it under the muscle. So that's, easy enough to do. If it's already under the muscle, I can do like a neo-subpectoral pocket and keep it under the muscle, but in a different position.
Right.
So if I can do a pocket change, I will. I always take out the entire capsule, which is job. That is a surgery in and of itself to get
Sure
all
is.
that capsule out. But I do think that that is going to give my patients the best chance of not recurring.
Yeah, I mean, I think those are all good things to do, and I think aggressive is a good way to go. You didn't mention putting in ADMs, acellular
Because
dermal
that's
matrix. That's super aggressive.
That's my next step. So I do sort of, okay, so the other technique for treating capsular contracture is to use what's called an ADM, or an acellular dermal matrix. And this is basically cadaver skin that's been washed, processed, treated. All the live elements have been washed away. And it's been shown, we saw this mainly in our breast reconstruction patients, that using this mesh with implants decreases the chances or recurrences of capsular contracture.
Correct.
The problem with it, number one, it's very expensive. Number two, it is another foreign body. That you're putting-
$3,000.
$3,000 and per sheet, per
A lot of
side.
money.
So, and it's another foreign body that you're already putting into an implant. There's an increased risk of infection. So it's not something I just throw in loosely. So I kind of gauge my patients. If it's their first time with capsular contracture and we have an obvious reason why it happened, maybe they're old implants, maybe they were above the muscle, I won't necessarily use it. If it's a recurrent capsular contracture, or if they just need a mesh for some other reason, maybe they have really loose breast tissue and they'd benefit from having some extra soft tissue support and they're okay with paying for it, then yeah, I'll go ahead and use that as well.
It does work,
It does work.
but it ain't cheap.
It's not cheap. And I think if you do all the other steps, you take out the whole capsule, you do the pocket change, you put in a brand new implant, you don't need to necessarily jump to that.
Right.
But if you fail all of those other aggressive steps, then yes, I use the ADM.
It's a lot of choices.
It's a lot of choices. And I think what is super important, and I try and impress this on my patients, and it's kind of funny because we just did a revision rhinoplasty podcast, and I like to think of these revision breast cases in a similar way. It's nothing like your first primary breast augmentation surgery. Your first primary breast augmentation surgery, you probably did fine. You were in and out, you were back to work in a week, and it was fine, and it wasn't maybe that expensive. But now when you're coming back and you're talking about doing removal of the capsule, changing the pocket, possibly putting in a mesh, and let's not even talk about if you need a lift or a mastopexy. This is a whole new ballgame of surgery. This surgery is 3 times as long and 3 times as expensive, and the recovery is definitely much more prolonged. It's not a little tiny primary breast augmentation surgery.
That is the truth. I mean, you have to recognize that revision anything is a different animal.
It's a different animal. And I feel for my patients when they see it's a sticker shock too. They see this cost of the revision surgery and it's like, that's not what I paid the first time around.
No, the first time they paid $10,000-$12,000 for, or less.
Or less, depending where they are. Now, I mean, looking at easily $20,000.
Yes.
Or more, especially if you're putting in the mesh, because it's a big surgery and it takes a long time. That capsulectomy, taking out the whole capsule, that is a whole separate surgery in itself. It takes a long time.
Yeah, there's serious work involved.
Yeah.
And the reason that these revision operations are expensive is because we've got to take care of these patients a lot. They require tons of follow-up.
Yeah.
We just can't say it enough that the follow-up is key.
Follow-up is huge. You are going to have drains, one on each side. Those drains will stay in place for anywhere from 2 up to 3 weeks. And I'm kind of a meanie. I'm mean mom. I don't let my patients shower when they have their drains in.
You are a mean mom.
I am a mean mom. And that's the one thing they really want is to take a shower. But I just
it drains
I get so paranoid about infection and tainting the field. And sorry, sponge bathe.
How about no?
You
are not getting to shower till these drains are out. But once the drains are out, you're all good.
Once your drains are out, you're fine and life gets substantially better. But those 2 to 3 weeks that you have the drains in, you're going to be kind of grumpy,
Well, I mean, you got to do it, especially if you do, these big wide capsulectomies. I mean, they weep fluid, and you don't want fluid
you don't want your fluid